Good morning, everybody. I think we should start this very interesting morning session that we have on immune aberrations and MDS. I'm happy that my co-chair is now entering. Great. But let's get started because we have a full program, so we can get you through in time. So there was a change of program for the first speaker, but we are very happy to have Olsnes Kittang here to tell us about myeloid dysplastic syndrome and myeloid cells, suppressor cells in that context.
Thank you. First of all, I would like to thank the organizers for giving me this opportunity to present about myeloid-derived suppressor cells in MDS. And I have no disclosures. So first, I want to show this beautiful slide by Sharam Kodasti, showing the pathway of immune pathogenesis of MDS, starting with pre-MDS inflammation and chronic smoldering inflammation in the bone marrow, leading to apoptosis and stress of hematopoietic stem cells, and then recruitment of immune response due to antigen spreading, both innate and adaptive response, and the protective T-cell response that we see in low-risk MDS, which also is a part of the pathogenesis inducing cytopenia and bone marrow suppression. In low-risk MDS, we have mainly Th17 cells accumulating, but eventually more suppressive cells are recruited due to this chronic inflammation, and finally then more immunosuppressive environment is created. And MDSCs, here, the myeloid-derived suppressor cells, are central in this switch from a very pro-inflammatory to anti-inflammatory environment, and immune subversion, and finally disease progress to high risk and AML. So what are MDSCs? It is a group of immature cells, myeloid cells, who are in a specific state of activation. And these cells, this activation leads to very distinct immunosuppressive function. And MDSCs, since they are immature myeloid cells, they can differentiate into granulocytes, dendritic cells, and macrophages. And it has been shown that these cells accumulate in many cancers. But like solid tumors, oh, sorry, that was not the right one. Both in solid tumors, but also in hematopoietic malignancies. But these cells also accumulate in acute stress situations in the organism, like burns, infections, and in chronic inflammation, like in autoimmunity or GVHD. And in these situations, their task is to protect the organism or the tissue from extensive damage from this very enhanced inflammation. So the anti-inflammatory effect is protective and needed. And we also see accumulation of these cells in physiological situations like pregnancy and in aging. Sorry, wrong way. Okay, so we are all familiar, or at least the clinicians are very familiar with the term left shift in the hematogram. And that is well known for many, many years, that in stress situations we have higher levels of less mature myeloid cells, like band forms, and less mature neutrophil forms. And this is seen, of course, in stress situations, but and the cells are not different from normal immature myeloid cells. And that is also true for the MDSCs. So they don't have a specific look or morphology. They look the same as all immature myeloid cells. And they also have similar immunophenotype, as I will show you. So it is also well known that these immature myeloid cells accumulate in cancer. And already in 1929, it was described by Sonnenfeld that leukemic reaction can accompany carcinoma. And in the late 70s, it was shown that these cells actually have T-cell suppressor activity. And they were identified as what was then called natural suppressors. These cells, when they were inhibited, and that was shown later in the 90s, it could actually inhibit the tumor growth. And more interest there was more and more research in this field, and more work showed that these cells actually have an important role in cancer progression. And during the 2000 and after, they also found mediators and drugs that could modulate or regulate MDSC numbers in cancer patients, like, for instance, sunitinib and COX-2 inhibitors. And also transcription factors that were central were identified, like STAT3 and other regulatory factors like S100A8 and 9 that are important for the activation of MDSCs. In 2003, it was shown that ATRA, all-trans-retinoic acid, could reduce MDSCs in tumor-bearing mice and also differentiate them in cancer patients. And there has been a lot of research on these cells, trying to identify them in various cancers. But first, in 2013, the first paper on MDSCs in MDS arrived, and that was by Chen and co-workers, titled Induction of Myelodysplasia by Myeloid-Derived Suppressor Cells. And later, there have been some other papers, and in 2017, a very direct targeting effort with the Fc-engineered CD33 antibody was also published by Xiaoliu and co-workers. So MDSCs, they have a very complex mechanism of inhibiting T cells. They're not just doing it by one inhibitory way. They do it in many ways, and one of the ways is by increasing the number of Tregs and recruiting Tregs to the tumor microenvironment. They deprive the T cells of necessary amino acids and starve them by releasing arginase. They inhibit T cells and lymphocytes in general, NK cells, by releasing inhibitory cytokines like TGF-beta and IL-10. And they also interact with the T cell receptor. So there are many ways. The Treg expansion will be discussed more widely later by the next speaker, Dr. Kodasti, so I'll not talk anymore about that. But the immunophenotyping of MDSCs, as I said, there is no specific immune phenotype that can really exclude other cells. There is no exclusive marker. But we divide them generally in monocytic MDSCs and polymorphonuclear MDSCs. And monocytic MDSCs are HLA-DR negative, CD11b positive, CD14 positive, CD15 negative, and CD33 high in human. And polymorphonuclear MDSCs are HLA-DR negative, CD11b positive, CD14 negative, CD15 positive, and CD33 dim. And this immune phenotype is consistent during different states like cancer, inflammation, and infection. And this is from a review that is where the goal was to make a consensus how we are going to immune phenotype these cells, because many different researchers have been looking at MDSCs in many different diseases, but different panels have been used, and until now there has not been really consensus. It's not enough to do the immune phenotyping, because then you just find a group of cells where you know that you have an enrichment of MDSCs, but you don't know really which cells are the MDSCs. And to show that the cells that you have are true MDSCs, you need to show their suppressive function, and that you do by performing human functional tests, which can be done in allogeneic system or autologous system. And they are basically, it's all about showing that you can inhibit T-cell proliferation or T-cell interferon gamma production by adding MDSCs to a T-cell culture. Or in the autologous system, you can do the reverse. You can take out the MDSCs and show that the T-cell proliferation is improved. So it's not really straightforward to identify these cells. And in MDS, it's even more complicated because immature myeloid cells are very often accumulated in MDS because we have disturbed maturation. That's one of the hallmarks of the disease. And possibly also we see increased levels of blasts in bone marrow and in peripheral blood. And these blasts, it's not really easy to get rid of them when you do the immunophenotyping because they have aberrant immune phenotype and they do not always express CD34. When it comes to the PMN MDSCs, there is frequent granular cytopenia in MDS, and thus a very, very small population of cells. And on the other hand, there can be monocytosis in the blood, which is relatively reactive. And there can be interference with other causes of MDSC expansion, like infections in MDS patients or high age, which is also very typical for MDS patients. So, and also when it comes to this functional proof, then those assays might be very difficult to perform because the T cells that you harvest from the patients are already very strongly inhibited. So the autologous assays are very difficult. But it has been done research on MDSCs in MDS, and as I said, the first paper was from Shen and co-workers, and they showed that in comparison to control and non-MDS, there was a high level of MDSCs in MDS patients. We later did some more analysis, and we also showed that here in 42 MDS patients, we harvested blood and bone marrow and performed the same analysis or immunophenotyping on fresh blood and bone marrow. And we found that the MDSC's levels also are higher in MDS compared to healthy donors. And here. And also the MDSC numbers increase as the risk risk score increases. We also show that these MDSCs from MDS patients suppress healthy donor-affected T cells, both the proliferation and the cytokine release. I'm not quite finished yet with the Shen's paper because in that paper they also presented the mouse model, the S100A9 transgenic mouse, that has an accumulation of myeloid-derived suppressor cells in the bone marrow and progressive cytopenia, so an MDS phenotype. And they show that S100A9 actually, through signaling binding with CD33 and signaling, is associated with MDSC activation and suppressive function. So S100A9, as I mentioned earlier, is a regulatory protein. It's expressed both in the cytoplasm and in the nucleus, and it has a lot of functions regulating immune response. But they are both activating myeloid-derived suppressor cells, and they are produced by myeloid-derived suppressor cells. So there can be a very strong positive feedback loop. But when they inhibited S100A9, they were able to reduce the level of inhibitory cytokine production, you see here, and they also rescued the hematopoiesis that you see here. So S100A9 was believed to be a very good target for treatment of MDS. But as we see here, the level of expression of S100A9 is decreasing as the disease is progressing. This was presented at ASH 2016 by Paul Brent Farrell and co-workers, and they showed that in 3 patients that first had MDS that transformed to AML, the S100A9 levels dropped dramatically. And So this is not such a good target in higher risk MDS. But we can target the effects of S100A9 by inhibition of PD-1, PD-L1, because those are induced by S100A9, and thus the high level of these of PD-1 is found on precursor cells in MDS bone marrow, so erythroid and myeloid precursors, and also on MDSCs. The PD-L1 is highly expressed on MDSCs from MDS patients. So when they inhibited, this is the work of Cheng published this year, when they inhibited with anti-PD-1, they were able to rescue granulocytopoiesis, both with inhibition of PD-1 and PD-L1, both granulo and erythropoiesis was rescued. Another way of inhibiting MDSCs can be, as I previously also mentioned, by the use of ATRA, as it ameliorates anemia and reverses MDSC effects in another mouse model, the DKO mouse, which has an age-related inflammation and anemia. And this the figure I chose to show you shows that when you treat with ATRA, you have an increase of CD4 positive T cell proliferation. So you so you reverse the immune inhibition. And of course, you can also target more directly, target the MDSC population with the anti-CD33, and that is actually the approach that has reached to clinical trials. And there are 2 clinical trials that are targeting CD33. The first is the Fc-engineered anti-CD33 monoclonal antibody, and that is actually now an ongoing phase 1/2 clinical trial. And the second is a tree-specific killer, so it's both CD16, IL-15, and CD33 cell engager, and this is also registered in clinicaltrials.gov, but it's not yet recruiting patients. So to summarize, I want to say that cells with MDSC phenotype and function, we have seen that they are expanded in MDS patients, and their numbers increase with higher risk disease. And the importance of MDSCs in the suppression of hematopoiesis in MDS has been demonstrated in 2 different animal models that I showed you, the S100A9 transgenic mouse and MDR1/MIR146A double knockout, or DKO mouse. And we can target MDSCs in MDS directly with the anti-CD33 approach, or indirectly through differentiation with ATRA, or with inhibition of important activating regulators like S100A9, and inhibition of, or checkpoint inhibition. So that was everything. I want to thank also my co-workers, and especially Sharon Cordasti, my mentor from London, and all of you for your attention. Thank you.
Thank you very much, Astrid. The talk is open for a question. There's one there.
Hi, Moshe Mittelman, Tel Aviv. Very nice presentation, nice data. Question. We, as well as others, have shown that erythropoietin have additional effects in addition to the erythroid series, including receptors on dendritic cells, macrophages. Do you have any data or idea whether EPO or ESA might do anything to these suppressor cells?
To myeloid-derived suppressor cells, I don't really have no.
Okay.
No, I don't.
Might be interesting. Thank you.
Yeah, it's very interesting.
Right, there's another question.
Hi, I'm Ari Yagunidis down here.
Hi.
from Düsseldorf, Germany. I just have a comment. I want to challenge a little bit the whole story of myeloid-derived suppressor cells. Not because I don't believe that they play a role, but rather because the entire story seems a little bit too simple. For instance, chronic inflammation leads to myelodysplastic syndrome. I mean, we have thousands and thousands of patients with chronic inflammatory diseases, from Crohn's disease to colitis ulcerosa, etc. And they don't have any, and we don't have any evidence that these patients have more myelodysplastic syndromes than other populations. The second thing is that I do believe that myeloid-derived suppressor cells do play a role in lower risk MDS, but once you have initiation of a higher malignancy state and you expand your blasts, why would you actually have higher numbers of, why would they grow with your blast count? You know what I mean. Why would the number of myeloid-derived suppressor cells grow with your blast counts while this expands through RAB1, RAB2, and then goes to acute myeloid leukemia, where the myeloid-derived suppressor cells would then abund? And the third point that I find a little bit difficult, and I'm just saying this because I think research should go into that. I mean, we have done tons of studies with all-trans retinoic acid in myelodysplastic syndromes, etc. It has no effect whatsoever. And while it does have certain effects in some subtypes of acute myeloid leukemia, in myelodysplastic syndromes, especially in lower risk disease, it has been a complete failure. And therefore, I just want to stimulate a little bit more research in this interesting field. I don't think it's quite that straightforward as we discuss it at the moment.
I agree with you. Just to help me to remember the three questions. The first was, what was the first question again?
maybe it's like
I'm sorry, I talk too much.
Comment.
No, but anyway, I don't. Yeah, it was if these MDSCs are like an initiating cause of MDS, and why in inflammatory diseases you don't see MDS so often, or yeah. So I don't think they are initiating event. They come when the initiating event already has been there, and you have inflammation and genome instability and accumulations of mutations, and then you get inflammation, and that is what recruits the myeloid-derived suppressor cells. So you need this genomic instability, and of course most patients with autoimmune diseases don't get leukemia, so they don't have this same degree of genomic instability. And regarding the whole story of MDSCs and ATRA, I also don't believe that there is one drug that can eliminate those cells or inhibit their negative effects in MDS. But I just wanted to show that in MDS we do now see some targets, and that it has been shown in animal models that they are effective when you inhibit these targets. But as in MDS in general, probably we need to have more combinations of therapy than just one drug.
Okay, thank you. I think we need to proceed indeed. It's a very it's a delicate balance, so there are many interactions that can play a role here.